introduce Dr Amanda Beech to start our meeting off today. Oh, okay. Oh, Stephen's just gone through. Well, I was not. Well, we can. Okay, well, while we're waiting, I'll just go through some housekeeping. Thanks for everybody for coming now to join us for the update meeting. Some housekeeping will start. Important information: bathrooms are on level 0, level 1. Follow the signs. One just straight out this door and down to the corridor to the right. The fire exits are located on level 0. Please follow the staff in the event of a fire or an emergency. Could I request that all mobile phones are switched to silent? I know that some people may have to take calls during the meeting. You can have them on vibrate only, and if you do need to, please respect the rest of the audience and step out of the room so as not to disturb the meeting. We ask that no food is eaten in the lecture theatre this afternoon. And we are going to try and be as comprehensive as we can this afternoon. The idea is to make it as interactive as possible with questions at the end of each session. But please keep in mind that we not only have the room full of attendees that you can see before you, but we have an audience online as well. And so there'll be questions coming from that audience as well. So if you do wish to ask questions, please keep them succinct and to the topic, and we'll try and get through as much as we possibly can. For those people who are online, there's a Q&A option throughout the presentation. If you submit any questions through that, we'll try and pick them up and have them covered. We may not cover everybody's questions, but we'll do our best to cover as many as we can. And at the end of the meeting, make sure, please, that you do the evaluation and survey so that we can keep presenting quality presentations to you as part of this meeting, and also address things that are relevant to you in your practice. The QR code's included in your information pack, and the evaluation survey will pop up on a screen. We'd also like to acknowledge some sponsorship today. CESPN greatly appreciates the support of today's event sponsors. We've had Bayer Pharmaceuticals, Bess's Healthcare, Janaea, Randwick Women's Imaging, and Ultrasound Care. So if you haven't, I hope you took a moment to speak to them over lunch. Just a little bit of a kind of important note. A record of your attendance will be passed on to our sponsors. Only your name is provided and the name of your practice. If you do not wish to have a record provided to the sponsor, could you please let our organisers know so that can be edited, so the CESPN staff can attend to that. Lauren's over here if you wish your information not to be disseminated in that way. So we're looking forward to your feedback, because this is how we plan for future meetings. So please make that constructive feedback if possible, and we'll try and cover as many things as we can. Just while I think of it, from this morning's meeting, anyone who was at the antenatal intake meeting this morning, a question came up about following up medical problems in pregnancy in the postpartum period. And we've confirmed that the pathway to use is to contact the obstetric medicine registrar via the switch. So we're talking about patients who are discharged after hypertension or diabetic interventions, just to confirm that the pathway is to contact the medical registrar via the switch. Thank you. I'd like to introduce Dr Beech to welcome you today.
Hello to all of you. Three in the country, the traditional owners of this land, past and present. We wanted to acknowledge all the women who own these lands. welcome to all of you. Thank you very much for attending, whether you're here or online. It's a sparkling day, as I found out today, riding in and plus intense this morning. So we do appreciate giving up that for this, and the emphasise again that we do appreciate all the help that you give us in the care of women. Now, as far as the Royal Hospital for Women goes, a number of things have happened this year. We've had an accreditation, which went very well, I must admit. A lot of work went into it. These are very particular, these accreditations. There are the ANSC standards, accreditations are higher. A lot of work went into that, and that all went very well. The next thing is that we had the final wrap up for a resilience review, which occurred 2 years ago in response to a series of adverse events that happened in hospital, mainly in relation to a series of unexpected cluster of hypoxic ischemic encephalopathy. All those babies, fortunately, in follow-up are doing very well. There was, rather than just a bland external review, what the health department does now is a resilience review to see how the organisation, I suppose, can bounce back and adjust to these things in the future. There were several perhaps critical comments there that we had to take on board. And again, a lot of work has gone into that. So I suppose it's all about cooperation, how we cooperate and work together for safety with our general practitioners, obstetricians, midwives, allied health, and of course the women themselves. And again, that went very well. That just occurred the other day, and we received very positive feedback from the health department. In addition, that initiative, which has seen a decrease, a noticeable decrease in cases of preventable HIV, that's been the subject. We've been granted an award through the Southeastern Sydney Local Health District. So all of that's very positive. Now, there's two other things I need to tell you about. The first thing is that we have a wonderful general manager, Dr. Garland. We have wonderful midwifery leaders, and I think the leadership is very go-ahead. Now, Donna Garland has always been keen on the idea of developing a unity of vision about what we're doing at the Royal Hospital for Women, and hence we have this vision, the way forward at the Royal Hospital for Women. I'm not going to go through all of it. I just want to get you to get a flavour of it so that essentially you can join in the love, so to speak. This is a clinical redesign project to create a contemporary maternity service so that we do respond to consumer voices. It's clearly related to the newer and just about to be released, although it's about to be released for last year, the new health policy, which replaced Towards Normal Birth, Connecting, Listening and Responding Maternity Care in New South Wales. You will hear about that. We've seen drafts of it, and again, we've tried to find what's written up with that. Look, you're all aware of the standard measures of quality of maternity care. I don't want to dwell on those. These are the hard numbers, so to speak. We wanted to, this was going to be based on what we found that women valued and what they experienced. I'm not going to go through all those. I just want to say this is how this was developed. So we wanted to offer care through a different lens and focus on what women expect, which is a series of things. These are all self-evident, but the focus is on the creation of the mother. And I suppose, you know, just lately seen a steady stream of women. The uniform message after their birth was, I just felt so great after that. Just won't forget that. It was great to see you working as a team. So in my position, I cannot hear anything better than when women say that we work as a team. I don't want to hear anything about myself, all right, that I'm good or something like that. I want to hear them say we work together. When they say that, that just leaves such an impact on them. And that's what we want here. We want them to feel better because so it's a whole clinical redesign format. It is very particular. It's not just a series of motherhood statements, pardon the pun. It's about all these things. It's about the models of care, and it's thinking very carefully about how we want GP shared care to work, so that it's the most substantial part of our care. It's about the birth environment, interventions, etc., etc. We have several working parties, and clearly we'll be relaying more about this through the GP shared care network, the HN, and we're wanting your involvement as well. Language and communication, the team, and all of those positive things which we like to see in healthcare. And essentially, it's acknowledging that pregnancy, birth, and the early postnatal period are a unique, intense, and transformative psychological experience that can generate empowerment, esteem, confidence, and accomplishment that remain with women throughout their lives. And that is the vision, all right? So that's one thing, and we'll keep you posted on it. Now, the next, if I could just briefly, there's just one other. Oh, good. Okay, yeah. This has just evolved recently. There is currently, through Women's Health Australasia, wonderful organisation, multidisciplinary, all about healthcare for women, heavily oriented towards maternity. This is a collaborative exercise amongst 50 hospitals Australia-wide to try and reduce preterm births. Now, it's hot on the heels almost of the National Collaborative to Reduce Major Perinatal Trauma, which I must admit, it was a success. The achievements perhaps statistically were modest, but it still was a success. People were working together, lots of exchange of ideas. This is the same. Now, preterm birth, you know why we're concerned about it. Preterm birth rates generally are on the rise, all right? That's the concern, right? And the two areas of concern are clearly the very early preterm births and then the later preterm births. Dr. Coogan and I will remember where previously we were almost blasé at times about delivery at, say, the 36, 37, the baby will survive. Well, you know, the latest data shows some concerns about the possibly compromised brain development if you're too perhaps laissez-faire about that. So this is 50 hospitals Australia-wide. We've had our first meeting out at Homebush with representatives of these 50 hospitals. There will be further meetings in Brisbane and Melbourne. And the aim of the game is to reduce early term and preterm birth by 20% by March 2020. It was a very ambitious aim, yeah?
What do you mean by term?
Okay, so what we're prior to 39 weeks, all right? These are our team members. I think the critical people there are Antonia Shan, Sarah Lyons, there's our general manager, our data manager, and the head of MFM, and the outpatients manager, Fiona Donovan. So our baseline data, sorry, I just wanted to get to the, sorry, there was an aim there, somehow gone. It's been eaten up by something. So the two components of this is we want to reduce the early preterm births, but then we want to minimise the number of elective births that are happening before 39 weeks. Clearly, there are some indications for those. However, we are going to be much tighter about those. So particularly in cases sometimes of milder blood pressure, perhaps cholestasis, we're not as insistent now about inducing 37 weeks and a range of indications, right? So we want to develop a tightened up list about that. Likewise, particularly elective caesarean sections, leave them till 39 weeks, unless there's a fairly compelling reason to do it earlier. So they're the two components. And of course, the reasons for that are the obvious adverse effects, long-term effects of preterm birth, short-term, but then the later, closer to 39 weeks, it's the issue around brain development. And just to know, let you know, this is our baseline data. Our early, that late preterm birth is around 21%, and the preterm birth overall is 7%. We don't do too bad on those early pretermers. We were slightly surprised by those later preterm births. Now, we want to keep an eye on NICU admissions at stillbirths, however, to making sure that they're not happening in excess. The main components of this are cervical length screening, and we will send out the guidelines and recommendations regarding this, and we will be communicating with radiology practices about this, and particularly if there is a length of less than 25 millimetres, there are specific actions in response to that. Vaginal progesterone will be recommended according to certain indications. And remember, the evidence for vaginal progesterone, particularly where there's a short cervix, is, becoming more and more compelling. Initially it wasn't, but now you can see that fairly with the larger data sets that you've got that 40% reduction when using vaginal progesterone. So we do have a preterm birth clinic. We will be looking at continuity of care as much as possible, because again, in the meta-analyses, that's been associated with the reduction of preterm birth. Agreeing on indications for planned birth less than 39 weeks. Now, this is all on the web. There's a very nice graphic about the brain development, a very nice graphic about the actual measures that we're going to take, and I think they're all very useful. They were meant to be in this set of slides, however, the usual cyber confusion, which I'm prone to. So we will be communicating to you more about this through the network, and I think this is a wonderful initiative, and certainly we'll keep you posted about results, interim and final. Thank you very much for your attendance, and look forward to having a good.
Thanks, Dr. Bissett. Now I'd like to introduce our first speaker for the afternoon, Amanda Beech.
You guys can probably see this outside. You're probably aware of it. It's a fantastic publication. Every pregnancy is available on the New South Wales website as a downloadable form. Been out of print for reprinted, but it's a really remarkably good resource in a kind of manageable form. So if anybody is uncertain what it is, I can highly recommend it.
Thanks, Dave. Again, sorry, I'd like to introduce our first speaker, Dr. Amanda Beech. Amanda Beech is an obstetric medicine physician and endocrinologist with an interest in women's health across all ages. She has a breadth of experience in preconception counselling and managing medical disorders of pregnancy. She has a special interest in reproductive endocrinology, menopause and osteoporosis, including the prevention of secondary fractures in women and men with osteoporosis. Amanda is the clinical lead for the osteoporosis refracture service at the Royal Hospital for Women, as well as the bone density unit, and she is co-chair of the ACI's Menopause Task Force, which aims to expand publicly available menopause services to women across the state, as well as provide support and educational opportunities for clinicians providing their care. Please welcome Dr. Beech to speak with us today.
Set myself a timer, because otherwise I'll talk forever. That audio is okay? Fantastic. So thank you so much to the organisers for inviting me to speak today, and thank you for giving up your afternoon. I'm going to talk about something on the complete opposite side of obstetrics. So these are all things menopause and bone. So very quick outline. I'll talk about osteoporosis. I'll talk about menopause, with a big focus on menopause today, because if you're anything like me, we got very little menopause training as we came through the registrar and consultant ranks. So from a menopause perspective, these are the two resources I find the most useful. They are a couple of pages of basically everything you ever need to know about menopause, how to approach it in a primary care setting, and what management principles to follow. So use these if you'd like to. They are fabulous resources. I use them all the time. And if you listen to nothing else that I say today, just follow that slide. So as a perimenopausal woman, I would hesitate to encourage other people to, but menopause is a time of real transition for women. And I think of it in terms of a healthcare provision perspective. I think about it as this, this trigger point, or this pivot point between a woman's reproductive life and a woman's preventative care or prevention of a disease perspective. And that's how I approach it. So menopause for me is very much about not only treating the symptoms of menopause, but thinking about all of the breast cancer, cardiovascular risk, stroke risk going forward. And that's how I approach it in my practice. So we know that the actual definition of menopause is the final menstrual period, but that can only be, it's a retrospective diagnosis. You have to have 12 months of amenorrhea before you get there. So often it's a difficult decision in terms of whether a woman's truly postmenopausal or not. But the diagnosis is very much based on a clinical assessment of the woman. And can you see that? No, I'll have to use the clicker. If I can work out which it is. So yes, so when we're thinking about the final menstrual period, what precedes that in the 2 or 3 years before is the menopausal transition, what we used to know as the perimenopause. And from my clinical practice, this is the time at which women experience the greatest symptoms. They often have terrible hot flushes in this perimenopausal period. They often experience symptoms, anxiety, mood disorders, mood changes, quick to irritability, quick to anger. And those are the things that affect, or that they worry about the most in terms of their day-to-day functioning in life. It's divided into the early and late transition periods, or the early and late perimenopause, and that depends on the frequency of their menstrual cycles. So initially the cycles will go from quite regular, and then they'll become slightly closer together and maybe slightly heavier. And then they tend, in that final year before the menopause, they tend to just become further and further apart and lighter and lighter. So in this, in that transition phase, they often don't know when their period is coming. It causes a lot of issue, and obviously they have all of these symptoms that are present: the vasomotor symptoms, the hot flushes, the night sweats, the mood symptoms, particularly anxiety, but also depression, that I'm not sure if you've noticed this, but they tend not to be so responsive to our normal antidepressant or anti-anxiety medications. And there's increasing data to show us that in this population, they respond better to hormone replacement than they do to antidepressant therapy. So it might be that that's a practice point to consider, maybe utilizing some hormone replacement to address anxiety and depression in this population. As we then transition through the menopause, you can see you've got early menopause and late menopause. Slowly those symptoms will improve, and what replaces it in the 2 to 3 years postmenopausally are those genitourinary symptoms that women really describe, and those can persist forever, but they respond very, very nicely to topical estrogen therapy with Ovestin or Vagifem. And I do apologize for using brand names, but There are not that many in this area, so I feel like we can do it reasonably. So the consequences of menopause they're around increased cardiovascular risk. So you have a big change in your cholesterol in your lipids, and you lose the protective effect both of the HDL and of the estrogen that is now no longer being released. There's also the thing that women tell me about the most, other than their hot flushes, is this change in weight. So that central adiposity becomes much more. And it's obviously that central fat is the metabolically active fat. It's the one we don't like. Increases insulin resistance, makes weight loss harder, is more prone to increasing cardiovascular risk and stroke risk. And so it's really diet and a focus on exercise, although it's 99% diet and 1% exercise from a weight loss perspective. It's also quite a significant complaint at this time. Now, the studies tell us that the actual weight gain of menopause is 3 kilos. When I tell that to my patients, they roll their eyeballs at me. But I suspect it's because when you're not feeling well, there's if you're having hot flushes, if you're having night sweats, there's an increased chance that you might reach for that glass of wine in the evening, or reach for cheese and biscuits or something like that. So I do think that it's an environmental thing, and I think we need to think about it in that setting. There's some data on dementia. There's some data on dementia, balance osteoarthritis, but there's not a huge amount, although I think it's increasing. Certainly dementia for me is one that it would be very pleasing to demonstrate an improvement if we give hormone replacement. Thank you. So this is, how can I describe this? This is the devil in the in the menopause setting. And the Women's Health Initiative study really is the reason that we have so little information and that we know so little about menopause, and that it hasn't been taught for many years. So I'm an endocrinologist. Hormone replacement or hormones is our primary focus, and there is no menopause teaching in endocrine training. So it's far more common than diabetes, but we're not trained on it. And it's because of this study released in 2002, about 24,000 women on hormone replacement therapy with Premarin, which horrifyingly stands for pregnant mare's urine, which is where they got the hormone from, or the hormones from, as the estrogen component, and medroxyprogesterone acetate, which is a particularly unpleasant progestin. The mean age of recruitment was 63. Now, we know we would not start hormone replacement therapy for the first time on anyone at the age of 63. And certainly they had significant comorbidities. So it really wasn't a fair test of hormone replacement. And the studies reported 29% increase in heart disease, a 41% increase in stroke, a 26% increase in breast cancer. And that was what was reported. I'm sure those of you who remember these headlines, that was what was reported, even though it was actually a reporting of the relative risk rather than the absolute risk, which was very small. Of course, what happened is no one took hormone replacement therapy anymore. Lots of women had severe symptoms because their hormone replacement was taken away. And because of that, they probably have now a worsening outcome in terms of their long-term heart disease and stroke risk. So how do we diagnose it? It's a clinical diagnosis, thank goodness. As a physician, I love clinical diagnoses based on symptoms and menstrual cycle. If you've had a hysterectomy, you can have an FSH and an estradiol level. If the FSH is greater than 35 and the estradiol level is low, that's diagnostic on 2 occasions, needs to be on 2 occasions. And you don't need to use AMHs or progesterones in this setting. An AMH does give you an idea of follicle count, but it doesn't give you an idea of how long it's going to be until you go through menopause. I often get that question. If I do an AMH, can you tell me, is it 1, 2, 3, or 4 years? Yes. Turn the volume up. If I talk like that, is that better? No? Can we turn the volume up at all? No, I will just talk louder. How's that? All right, wonderful. I can talk louder. So management principles. So start hormone replacement therapy within 10 years of the menopause. And that's certainly something we recommend now. Nothing after 10 years because the cardiovascular risk has a significant uptick after 10 years. Before you start, assess risk factors. So take a history. What else has this woman got going on? Does she have a history of venous thromboembolic disease? Look at her blood pressure, her smoking history, her BMI, her waist circumference. Think about her obstetric history. So here we go. We can talk about obstetrics now. A woman who's had a previous history of preeclampsia or a history of gestational diabetes is 2 to 4 times more likely to develop hypertension, diabetes, and cardiovascular disease as they age. Talk about diet, exercise, and physical fitness. And I hope that's the message that you take home today, is it's really important to assess all of these risk factors and address them. In terms of calculating cardiovascular risk, every woman over the age of 50 should have a cardiovascular risk assessment every 5 years. And this can be done very, very well in the primary care setting, in the same way as we look at doing your bowel cancer screening, mammograms, that sort of thing. This should be happening simultaneously, because the higher the cardiovascular the risk, the tighter you need to control their lipids, their blood pressure, etc. If you've identified risk factors in the history, then the utility of transdermal estradiol is significantly increased or is recommended. The reason transdermal estradiol is good is because it has no hepatic first-pass metabolism. It doesn't increase blood clot risk. It doesn't increase any adverse liver risks. It essentially is the safest form of hormone replacement therapy. So if you're at risk of anything, if you're at risk of cardiovascular disease or stroke or diabetes, then transdermal estradiol is the answer. Who should you send to see us? So we have a couple of menopause clinics here with a very long waiting list, but who should you send to see us? Who would be better probably managed in a high risk setting? It would be those with a previous thromboembolic event, either a DVT or a PE or a CVST, something like that. Anyone with severe endometriosis, because on hormone replacement therapy, they have a higher risk of developing endometrial cancer. Anyone who's had higher cardiovascular risk, because there's a bit of a nuanced decision as to whether they should or shouldn't get hormone replacement. Anyone who's had treatment for a hormone-associated cancer, like breast cancer or ovarian. Premature ovarian insufficiency, so somebody who goes through their menopause before the age of 40, absolutely essential. Progesterone sensitivity, a history of depression, a history of PMDD, those can be tricky from a progesterone perspective in terms of treatment, so they should come to us, and anyone who has a complex medical history. So definitely not the vast majority of individuals who are out there experiencing these symptoms of menopause. So when we're thinking about how do we treat menopause, we've only got 2 questions to ask. Number 1, do you have a uterus? Yes or no? Number 2, when was your last period, or how many periods have you had in the last 12 months? So this hopefully is a very simple slide. A hysterectomy is like the holy grail for menopause. So if I was a gynecologist, I'd refer everyone for a hysterectomy. But a previous hysterectomy, we would just recommend unopposed estrogen, and pretty much every study shows that all parameters are improved in long-term women's health if they have no uterus and are on hormone replacement. However, not the majority of our population, sadly for me. And so now we've got ladies who have a uterus. We need them to use combined hormone replacement because they've got the uterus. That needs to be protected. Oh, I think I've broken that. That needs to be protected with the progesterone component when we're giving estrogen. And so we would use either continuous hormone replacement therapy where we replace estrogen and progesterone together every day. And that would be if they have had 12 months of no periods, or they would have cyclical therapy, which is where we give estrogen every day to get rid of all the horrible symptoms of perimenopause, but they then have progesterone for only 14 days of the month, and they'll have a lovely regular period or breakthrough bleed, depending on what you want to call it, in between. I then do that for a year and switch them to continuous after that. Everyone gets an assessment in my clinic after 3 months. I want to make sure that I've given you enough hormone, and then we review them initially 6 monthly and then every year. And that review every year includes lipids, cholesterol, HbA1c, fasting insulin, fasting glucose. So what are the options for cyclical therapy? So the options for cyclical therapy, now here's the clue to my thinking. If they're in italics, they're available on the PBS. If they are in bold, they're a contraceptive. So that's my thinking. So for Mustin, and that should be 1/10 and 2/10, not 120 and 210, 110 and 210 for Mustin and Trisequence. Those are the cyclical oral forms. And essentially they work similarly to oral contraceptive pills, but they're not contraceptives. Really, I would very much stress, do tell your ladies that they're not contraceptive, because it is still possible to fall pregnant at 46 and 47. And we see it occasionally. Should I say my favorite? Yes, my favorite oral contraceptive pill or my favorite pill in this setting is Zoli. The reason I like it is because it's a body identical estradiol as opposed to ethinyl estradiol, and it's better for bones. So for me, that's my oral contraceptive of choice in the perimenopausal setting. I don't use it much before that, but in the perimenopausal setting, it works beautifully. They sometimes get a little bit of breakthrough bleeding in the first 3 months, but that settles down, and I use that in a vast majority of women. And it is contraceptive, so that's important. Transdermal cyclical therapy, there are some that are available on the PBS, so the Astalis Sequi, and then there are others that are the non-PBS and new ones, which are, I'm sure all of you have heard of the Estradiol and the Estradot. I've put Estradot here, and I should have put Estroderm and Climara as well, but the Estradot for me works best. I have the least complaints about it. Women like it. It's very small. It doesn't cause itchy rashes, and it's a twice a week patch that you just pop under your underwear. You can shower, swim, exercise, do pretty much anything with it. So it's either a daily gel or a twice weekly patch. So that's the estrogen component. And then you have to give them some progesterone, either oral Prometrium for 2 tablets for 14 days of the month, or my second favorite thing, the Mirena IUD. And that one is contraceptive, whereas none of the others are. Life gets a lot easier, excuse me, after the menopause. And we move on to continuous hormone replacement, either oral, and there are a number of combined ones such as Angelique, Famostin, Conti, or Cliovance. And then there are there's one very new body identical treatment that you've probably started to receive little pamphlets in the mail about, and that's by Juva, which is a body identical estradiol plus a body identical Prometrium or progesterone. I suspect that's going to become quite popular. It's just come on the market in the last 3 or 4 months. And then Tibolone, our old favorite. I love Tibolone. It's a really, really useful drug or useful tablet in this setting. So once a day tablet, 2.5 milligrams, and it can be really useful in women who've got some low libido along with all of their symptoms. Finally, the transdermal preparation. So again, you can use continuously a daily gel or a twice weekly patch, along with a once a day progesterone or the levonorgestrel IUD. So those are your options for treatment, and that's it. So how simple is menopause? We're done. Now, I've put in these slides because I have these laminated on my desk. I get asked this question pretty much every session. So with my patients. Now they say to me, but breast cancer is caused by hormone replacement therapy, isn't it? Well, the worst Women's Health Initiative study, the worst health study we've had in menopause, gives you a relative risk of 1.26. Now, this is really important information. You have a greater risk if your BMI is over 30, which is about half our population. You have a greater, significantly 5 times greater risk if you're over 65. If you drink 2 standard units of alcohol, and that's recently been reduced to 1.2, you have the same risk. If you're a current smoker, you have a doubling of the risk. If you smoke and have 1 glass of wine a night, you have a relative risk that's 5 times greater, 6 times greater. So the message that I provide to my patients is your breast cancer risk is minimal. You need to manage all of these lifestyle things. They are far more important from a long-term perspective. A similar message is from this great pictogram. Are you okay for me to? Yeah. A similar one is from this great pictogram. It is very useful. This pictogram is from the UK, but it's very similar data, right? So if you have women on hormone replacement therapy, that's that one. Very similar to if you're on the oral contraceptive pill or if you're drinking 2 standard units a day. But if you have a BMI greater than 25, look how much greater your risk is. And if you are doing 2.5 hours of exercise a week, you actually have a reduction. So this is part of my counseling when I talk about menopause. So when do we stop? The recommendations are changing. We used to say everyone had to stop by the age of 60. That's actually not true anymore. So there is a big change in the menopause sphere, which is encouraging us to utilize hormone replacement therapy in women in whom it would benefit, as long as we are managing all of those other things. We're making sure they're not obese, they're not overweight, they're not smoking, they're not drinking, they're exercising regularly. All those health messages that I think are so important. And we are regularly reassessing their cardiovascular risk. All right, I've used up more of my time to talk about menopause, so let's whiz through osteoporosis and then I'll take some questions at the end. So we know what osteoporosis is, so low bone mass, poor bone microarchitecture, and a higher fracture risk. So this is a significant problem in Australia. 1 in 4 Australian women have osteoporosis, so many more than any other, even more than cardiovascular disease. It's a huge burden of disease. So when women break a hip, they end up in hospital and 1% of them die within 12 months. 20% of them end up in a nursing home. So if we can prevent that from happening early, that's really important. And that's why we have secondary fracture prevention clinics in almost all hospitals in New South Wales. If we identify early fractures, we can identify those at risk of future hip fracture. So the menopause transition, I have to link menopause and bone. It's a great time to consider baseline testing for bone density in those women who have risk factors. So I wouldn't necessarily do it for everyone, but in those women who have risk factors at the transition time of menopause, this is a really good time to do a baseline bone density. And the people I would worry about were those who have a history of anorexia nervosa, those who have a history of a low trauma fracture, those who have a very significant family history or go through menopause early, those who are smokers and drink heavily, and those who have a history of rheumatoid arthritis, autoimmune disease, or a history of steroid use. If not at 50 or 51, which is the average age of menopause here in Australia, we would recommend at age 65 for everyone. So that's important. We should be thinking about bones in everybody. Because the diagnosis is not only our friend, the T-score minus 2.5. So that's what we learn in university. That's what we're taught, that osteoporosis is when your T-score is less than minus 2.5. So if we remember, osteopenia is -1 to -2.5. And then osteoporosis is just sitting here in the -2.5 and below. But in actual fact, there's also a clinical definition of it, and that is anyone who's had a low trauma fracture. So if you're off walking the dog and you trip over and fall and put your arm out and break your distal radius, that is the definition of osteoporosis, and those women should be assessed for risk. Now, you can't break anything. So it has to be, there are only a few bones that you can break: distal radius, humerus, 3 or more ribs, a vertebrae, a pelvis, a hip, and the tibia. They've actually taken medial malleolar fractures or ankle fractures out of the osteoporosis definition category, so that no longer qualifies. So how do we know who to treat? So there are lots of fractures out there. There are lots of BMDs less than -2.5. So who do we treat? And this is a change in practice, which is why I thought I'd pop it in there. How do we assess fracture risk? So in women who break something, or in women who have a BMD T-score less than -2.5, they need to be assessed for what their risk of hip fracture is. What their risk of fracture is, and that can be done in one of two ways, either using the Garvin fracture risk calculator or using FRAX. So the FRAX assessment tool was built in the UK, and it's very much for a European population. The Garvin is based on data taken out of Dubbo, and so we use that in an Australian population more commonly. One overestimates, one underestimates, but just pick whichever one you love and stick with it. So every fracture risk should be assessed. And if the 10-year risk of a hip fracture is greater than 5% and the 10-year risk of any major osteoporotic fracture is greater than 20%, that's when we treat. So I looked at the calculator. You don't have these slides because I only did it this morning. Apologies. So this is a 55-year-old lady, the one on your left. She's 55, she's got a T-score of -2.5, she's never had a fracture, never had a fall. And you can see there that her 10-year risk of hip fracture, 3%, any major osteoporotic fracture is 14%. So she doesn't get treated. Whereas this is exactly the same lady, and she's had one fall and one fracture. So you can see her hip fracture risk and her any major osteoporotic fracture risk has now moved her into treatment land. So what do we treat, or how do we treat? Lifestyle factors as the number one. So assess their calcium status. Dietary calcium is best. Assess their vitamin D status. The recommendation is actually that we don't test vitamin D in everyone, just in those who are at risk of low vitamin D, veiled women, women of color, women living in a retirement village or in a nursing home. They should absolutely be tested. I like to test at the end of winter just to give patients an idea of what their vitamin D is looking like. Strength and resistance exercise is a really important component of it, but even if you optimize all of those things, that's only about 10% of what bones like. It needs the estrogen, the other 90% is the estrogen. So as soon as you go through menopause, you've lost that component, and that's never coming back. Obviously, we talk about smoking cessation, alcohol use, and falls prevention, but that can be part and parcel of a bigger conversation. So I stole this slide from the Yale School of Medicine. Who better to steal a slide from? And it's basically about what to treat and when to treat, or what to use when. And you can see in those who are osteoporotic and young, around the time of menopause, they can have hormone replacement therapy. And we often don't even think about treating them with hormone replacement therapy because historically we're quite afraid of hormone replacement, but they can absolutely be treated with hormone replacement therapy. And then once they get over the age of 60, we can't, well, historically, we haven't used hormone replacement therapy in this population over that age. So we moved to the bisphosphonates and denosumab and the anabolic treatments, which I probably won't get to, but we'll see how we go. In terms of hormone replacement therapy, the options are really any of those that we've discussed. So if a woman is osteoporotic or needs treatment according to the fracture risk calculator, and they are under the age of, or they're within 10 years of menopause, you can pop them on hormone replacement therapy as a really good option. If they don't have symptoms, well, then we have our friend tibolone. So here tibolone raises its wonderful head again. I use tibolone a lot in the asymptomatic osteoporotic population who need treatment, who are under the age of 60. A half a tablet once a day just seems to work beautifully. You can't use it after the age of 60 because the biggest trial that looked at Livial demonstrated an increased stroke risk after 60, but it's perfect. You use it up to 60 and then you switch over to one of the bisphosphonates. My second favorite treatment are bisphosphonates, orals and intravenous. I've moved across to using Actonel EC almost exclusively because the enteric coated component of it has made it far more tolerable in women. I use these as first line, and I'm just going to bang on a tiny little bit about Prolia, because 10 years ago, I was the biggest Prolia convert in the world. I changed every single one of my patients from bisphosphonate therapy onto Prolia therapy. And what we've seen over the last 4 or 5 years is a side effect of Prolia that we never picked up, which is when you stop Prolia for a bone holiday, you lose a huge amount of bone. Up to 16% of their bone is lost in the 12 months after stopping Prolia. So the way I think about Prolia now is when you go onto Prolia, you're on it forever. So I use Prolia predominantly in a population over 75 or 80 when I'm never going to stop it. My favorite, bisphosphonates have moved back into my favorites from the anti-resorptive therapy perspective. But I will admit, what did they say? I drank the Kool-Aid. I drank the bisphosphonate Kool-Aid for 6 or 7 years. But my practice has changed, and most endocrinologists' practice has changed. And I just thought I would mention it here because I know Prolia is very popular in the primary care setting. So bisphosphonates have become our drug of choice again once we've moved beyond the ability to treat with menopause hormone therapy. This is what we're trying to prevent when we have our little bone holidays. So we treat for 5 years, stop for a year or two, treat for 5 years. And I've mentioned the denosumab. So in my slide, if I was able to, I would shift that over to 75 or 80. I won't talk about the anabolics because I want to leave a little bit of time for questions. So my last slide, or actually it's my third last slide because a couple of people have asked me to stick things in at the end. My last slide is the menopause transition is a fantastic public health and preventative medicine opportunity. You need to assess osteoporosis risk, assess cardiac and metabolic risk, treat for primary prevention, optimize lifestyle interventions, and introduce screening, including assessment for cardiovascular risk, along with starting the delicious hormones we have. So quick little plugs we now have a pre-gestational diabetes preconception clinic. So if you looking after type 1 or type 2 diabetic patients, even just those on metformin, I should say patients with type 1 or type 2 diabetes, and they're thinking about pregnancy, please send them to us. The referral is exactly the same way. I do all the referral triages. So send them through to us, the usual referral pathway, and we'll see them and optimize them pre-conception and talk about pregnancy. And then Dr. Shand asked me to put this up, which is a pre-babe study. So it's a study looking at women who are overweight or obese and planning a pregnancy in the next 6 to 12 months. And it's a diet and weight loss study looking at whether or not we can improve their pregnancy outcomes. So they're randomized to a delicious shake or healthy eating and exercise and all of those sorts of things. I think we've got time to take questions. Do we? I've lost timing altogether. On mine, it says 36 minutes. So are there any questions from the audience? Oh, wait. The lady up the back with the stripy shirt.
I had a question.
I can hear you, but they probably can't. Oh, I need to repeat the question. That's right. So what's your question?
I had a question about Zoli. Can you use that over age 50?
Oh, that's a great question. Thank you. And I didn't mention it. So over the age of 60, your risk of thromboembolic events increases 3 to 5-fold. Now, your actual risk is still very low. It's about 1 in 1,000. But I tend to transition them across. I say you can have your Zoli until you're 51. And then when you turn 52, I switch you over onto transdermal therapy. Yeah. Great question. The same with Bijuva. Yes.
You mentioned when to stop HRT.
Yes.
I think you're referring to keep an eye on their cardiovascular risk factors. Were you saying if their risk factors are very high, then we should continue it or stop it?
So if the risk factor for cardiovascular disease is really high, I would recommend sending them to us because it's a really tricky discussion. So there's some data that demonstrates an increased risk of cardiovascular disease. There's some data, probably a bit stronger, that suggests that your risk is decreased. It depends on how far you are away from menopause. It depends on what type of hormone replacement you take. So it's a bit of a nuanced conversation, and it's a lot about risk benefit in that setting. So I would probably, on balance, continue them to the age of 60 and stop if they've got super high risk. But if their risk is 5%, 6%, I might continue a little bit longer because that will actually reduce their long-term risk of heart disease because of the change to the lipids. Great question. Thank you.
Can I just clarify regarding bisphosphonates? We treat for 5 years, and then how long is the?
Oh, 1 to 2 years. So that just allows the bisphosphonate therapy to come out of the bone, and then we start the treatment again. So when the bisphosphonate therapy comes out of the bone, it starts the bone turnover again. I use the word freshen, but it's not right. You might lose a bit of bone density, but it's at the benefit of reducing their risk of atypical femur fracture, osteonecrosis of the jaw long term. But I should also state those risks are super low, right? So your risk of atypical femur fracture after 10 years of therapy, 1 in 1,000. Your risk of osteonecrosis of the jaw, 1 in 10,000. So really, really low risks. So if a person's particularly high risk on a calculator, you may want to think about leaving them on it longer.
Is there any reason why you wouldn't do a CT coronary calcium score on women with high cardiovascular risk?
Coronary calcium scores, because if they are 0, they make me really happy. So I don't use them routinely, but I know they are being ordered far more regularly now. And so if somebody comes to me with a really low coronary calcium score, I'm very happy. If someone comes with an intermediate risk on their cardiovascular score, I may consider sending them for one, because if it comes back low, I'm going to be much happier about starting my hormone replacement therapy. If it comes back higher, then that's where the nuanced conversation comes in. So I sometimes utilize it for risk stratification if I think they're intermediate risk cardiovascular disease, and it comes back negative. It's really a very positive, it's a good thing for us. What was your question, Dr. Cougar?
I know it's a special circumstance. Women perhaps in their late 40s and early 40s had endometriosis.
Yeah.
Surgical hysterectomy, oophorectomy, but the endometriosis is still there.
Yes, so the risk of endometriosis is around whether they had endometriomas before and ovarian endometriosis. So if you've had your oophorectomy and your hysterectomy, your risk is slightly lower, but we do worry about this. So that would be a case where we would use transdermal therapy in relatively low doses, and we would probably, even though they don't have a uterus, we might actually use prometrium in that setting because it's going to block, hopefully, any effects of the estrogen on the endometriosis. Now, the problem is endometriosis is super tricky, and it generates its own little bit of estradiol within the endometriosis deposit. And so sometimes it can feed on itself. So we monitor for symptoms. We sometimes do ultrasounds when they're on therapy, and we probably wouldn't leave them on it more than 5 years. I know I've taken lots of time.
Most of the online questions have been answered already. There was just one about, is the new combined oral contraceptive pill Nextstellis useful in the perimenopause? I've
not used it myself, so I guess I can be accused of being when you use something a lot, you use it a lot and you don't look at the alternatives. So I can't really answer that question.
Yeah, and I think you've just answered that with Stephen's question, but there was a question about, do you still need to use progesterone if a hysterectomy has been done for severe endometriosis? So I think
for mild or moderate, I probably would, be neither here nor there on it. But I think if you're severe, there's a reason to utilize it, and it's a reasonable theory. Yeah. Fantastic. Well, thank you to you all for coming, and I'll dash off.
Just like to take educating us all this afternoon. Thank you very much. Take this that was a really comprehensive discussion. So our next speaker is Joanna Pinder. Joanne is a clinical midwifery consultant who has worked within Southeastern Area Local Health District for 13 years. She's originally from the UK. We won't hold that against her. Joanna's professional career includes community midwifery attached to GP practices, home birth experiences, and the management of a tertiary labour ward. Joanna has an interest in workplace culture and how culture can impact patient outcomes. Joanna is currently leading the New South Wales Health Hyperemesis Gravidarum initiative across the Southeastern Sydney Local Health District. The initiative aims to improve outcomes and experiences for women who experience hyperemesis gravidarum through the implementation of models of care and clear pathways to access the care across the local health district, from primary care to inpatient management and everything in between. Joanna is motivated to ensure that women receiving maternity care are heard, validated, and respected in their decision-making. Please welcome Joanna to speak to us this afternoon. Thank you.
Hi, everyone. Thank you for having me today. I've heard apparently the microphone's doing funny things. So is there anything specific I need to do, or am I just good to go? Okay. So, yeah, thanks for coming.
Sound quality, I think, is... it has to be a little better. It's not loud enough.
I'll speak as loudly as I possibly can then, okay? Okay. So I'll first start with a welcome acknowledgement of country. I work across southeastern Sydney, so I'd like to acknowledge the traditional custodians of whose lands we stand, and the lands all our facilities are located on, the lands of the Darawal, the Gadigal, the Wangal, the Gweagal, and the Bidjigal peoples. I'd like to pay my respects to the elders past, present, and those of the future. So I want to talk to you all today about the southeastern Sydney Hyperemesis Gravidarum initiative, and I'm going to say HG because, quite frankly, it's a mouthful. It's an initiative to develop and streamline the pathways to care within the main service settings for HG. The new pathways to care will aim to improve integration between community and hospital settings and ensure that all women are identified with HG and nausea and vomiting of pregnancy, which I'll refer to as NVP, are identified, assessed and managed consistently and in line with best practice. Nausea and vomiting are common symptoms of pregnancy, with prevalence varying in different parts of the world. In a recent Australian observational study, 72% of women reported NVP, of which 42% had mild symptoms, 55% moderate, and 1% severe symptoms. NVP is experienced by about 69% or things doing weird things. Or 1.1% of women. This figure is likely to be underreported. HG is the main cause of hospitalization for women in the first half of pregnancy. It usually starts early in pregnancy, and some women continue to experience the condition throughout pregnancy. Care for pregnant women is shared across multiple sectors and services. Most often, pregnant women do not enter the New South Wales Health Service for pregnancy care until their 20 weeks gestation. Maternity care prior to this period is most frequently provided by GPs or private obstetricians. Care for HG during this time occurs across many service delivery settings, including emergency departments. There are many varied models of care across the specialities, services, and geographical areas. Information provided to women about HG management and treatment options is really variable. In particular, information about safety of medications and absence of consistent clinical care and guidelines and pathways have been noted to be problematic. Across specialities and LHD, there's variation in clinical views, attitudes, beliefs, and practices regarding HG. Adverse maternal and fetal outcomes have been seen in women who experience HG, including significant impact on emotional and psychosocial well-being. Women describe their symptoms as being trivialized or dismissed, and there's limited targeted education for assessing and managing HG, including multidisciplinary education across primary health networks, emergency departments, nursing, midwifery, obstetrics, gynae, and allied health, and primary care practitioners. The maternity service system and health professionals involved in a woman's journey have responsibility to ensure women are actively involved in decisions regarding their care, and at the same time, provide safe and high quality care that effectively manages risk to women and their newborn babies. In November 2020, the New South Wales state government made an announcement of $17 million commitment for the research and education and service improvements for women with HG. It's a 4-year initiative with the aim being to develop pathways to care within the main service settings for HG. The new pathways to care will aim to improve integration of hospital, community, and primary care providers to ensure that all women with HG and severe nausea and vomiting are provided clinical care that addresses symptom management, nutrition management, psychological support, home-based, and virtual care. So, just for a quick history lesson, one of the first written original accounts of the term Hyperemesis gravidarum was in 1897, when C.S. Bacon, an American physician, credited the term and its 3-stage classification to French obstetrician Antoine Dubois. Dubois first described HG during his address before the French Academy of Medicine, where he spoke about the finding of pernicious vomiting of pregnancy. The literature marked a milestone of change in the outlook upon the condition as a medical complication rather than a normal aspect of pregnancy. Charlotte Bronte's official cause of death was TB. However, there's speculation that she in fact suffered with HG. Charlotte Bronte's contemporary biographer writes, "At the beginning of January 1855, Charlotte was attacked by new sensations of perpetual nausea and ever-recurring faintness. A doctor assigned a natural cause, pregnancy, for her miserable indisposition and said that it would soon pass. The dreadful sickness increased and increased till the very sight of food occasioned nausea. From mid-January, she suffered from near continuous vomiting. She took to her bed, too weak to sit up. About the third week in March, there was a change. A low wandering delirium came on, and in it she begged constantly for food and even for stimulants. She swallowed eagerly, but it was too late. She died on March the 31st, 1855. And then, of course, in 2013, Princess Kate, pregnant with her first child, made the news after cancelling her first royal tour due to HG. And suddenly, everyone knew about it. So, nausea and vomiting in pregnancy. It's generally defined as symptoms of nausea, vomiting, and/or dry retching commencing in the first trimester without another cause. Like I've said, it's estimated to affect around 69% of pregnancies and often dissipates after the first trimester. According to the 2019 SOMANS guideline for the management of nausea and vomiting in pregnancy and HG, the most commonly cited criteria for diagnosis of HG includes persistent vomiting with weight loss not related to other causes, along with an objective measure of acute starvation, such as carbohydrate depletion, electrolyte abnormalities, and/or acid-base disturbance. In regards to weight loss, in order to meet the criteria, a weight loss of at least 5% pre-pregnancy weight is required. HG is a severe form of nausea and vomiting in pregnancy. It's generally described as unrelenting, excessive pregnancy-related nausea and/or vomiting that prevents adequate intake of food and fluids. HG is the leading cause of hospitalization and second to premature labor as the leading cause overall during pregnancy. So it's associated with a loss of greater than 5% of pre-pregnancy body weight, usually over 10%, dehydration and production of ketones, nutritional deficiencies, metabolic imbalances, severe fatigue and debility, depression, anxiety, trauma, premature labor or premature delivery, adverse fetal complications. It should be noted, however, that ketones are not always produced during HG, and therefore ketones are not required for a diagnosis of HG. HG usually extends beyond the first trimester and may resolve by 20 weeks. However, it can last the entire pregnancy in less than half of women. Complications of vomiting include gastric ulcers, esophageal tears, bleeding, malnutrition. It may also contribute to and worsen ongoing nausea. Just wanted to show this comparison table. So this is taken from the UK Pregnancy Sickness Support Organisation, and it breaks down the impacts of morning sickness versus hyperemesis. You can really see the distinct impact that HG has, and how if we as clinicians can provide appropriate care early, we have the opportunity to significantly improve quality of life. In terms of the psychosocial burden of HG, HG is considered to be a devastating condition for many women and their families. It can result in a loss of job and future career, as well as render them completely dependent on those around them. Some women are ill for only a few months, others for their entire pregnancy, vomiting until the actual birth of their child. And a small number of women continue vomiting postpartum for reasons unknown. It can be traumatic emotionally, and some women choose to terminate current and forego future pregnancy plans as a result. What we do know is that proactive treatment can alleviate some of the symptoms and lessen the negative impact on a woman's life. This slide provides some of the statistics in relation to the psychosocial aspects of HG on women. It highlights the significant negative effects on the physical and mental well-being of sufferers. I've also added the image from the HER Foundation, which shows the wide range of areas of the woman's and child's life that may be impacted. Further research is currently being undertaken to ascertain the full extent of impacts on children born to mothers with HG. In May, excuse me, in May on HG Awareness Day, which is the 15th of May, New South Wales Health posted 3 media tiles through their social media and on their Facebook page to promote awareness of HG. The post received an overwhelming response with a over 100% increase in web traffic compared to other posts. And they highlighted women's experiences of care. Glad to see more awareness about this. I suffered through 2 pregnancies, violently ill for 9 months, lost over 20 kilos each time. I've now got damage to my teeth and other health issues due to the amount of vomiting I did. It's not just the debilitating effects through the pregnancy on your body, but even the strain on your mental health and trauma and health problems you can be left with after it all. So many think it's simply morning sickness, when it is so much worse. For part of the initiative across southeastern Sydney, I've been engaged with women who've had hyperemesis and had their care across the district. And this is some of the quotes from the women who've had their care here. For me, the nausea began as soon as I found out I was pregnant at 5 weeks. What followed over the coming 6 months was nothing short of a living hell, vomiting up to 12 times daily, relentless nausea 24/7, unable to keep most foods down, and sometimes not even water. And I think the one that probably resonates with me the most is this one, because this is what women say time and time again, and all they feel is that they want to be validated. I begged my doctors to give this sickness a label and a meaning. They were more concerned with my BMI. I knew it was not just morning sickness. I just wanted to touch on the priority populations across Southeast Sydney. We have a really diverse population. 1% of the population identifies as Indigenous. 42% of the assessed population speaks a language other than English. And navigating the health system is challenging, even more so when historically there's a lack of trust in the system, or you have to navigate from a non-English speaking background. I think at St George, it's around 69% that speak a language other than English. So it's really important that we recognise and refer appropriate. It's nice to see Galu is at the back today, one of our cultural support workers. And I would encourage anyone who has a woman with HG to reach out to all the services available for those particular cohorts of women. So, New South Wales Health realised that we need clear guidance, especially around medication safety, providing care for this particular cohort of women, because it is challenging. In July this year, New South Wales Health published the Nausea, Vomiting in Pregnancy and Hyperemesis Gravidarum Guideline. It's accessible on the internet via New South Wales Health webpage under Publications. The guideline supports consistency of practice, decision-making, and care coordination regarding the diagnosis and management of NVP and HG in a range of settings. The guideline recommends that care settings may include community and ambulatory care settings, such as early pregnancy assessment services, pregnancy day stay, antenatal assessment units, emergency departments, inpatient settings, and virtual care. So what are the guidelines recommendations? Well, the first thing is assessment and investigation. It's recommended that all women are asked about nausea and vomiting in pregnancy at each of their pregnancy visits between 4 and 16 weeks gestation. If nausea and vomiting is present, assess and classify the woman's symptom severity using the tool that you can see there, the Mother Risk Puke 24 scoring system. Stands for Pregnancy Unique Quantification of Emesis. I would also recommend including weight loss and hydration status when making this assessment. The Puke 24 is a validated scoring system to classify the severity of nausea and vomiting in pregnancy over a 24-hour period, with 3 questions relating to the duration of nausea, frequency of vomiting, and dry retching symptoms. Weight loss I've already talked about. Weight loss of 5%, and that's pre-pregnancy weight. So anytime you weigh someone, it's important that you actually weigh them and calculate it based on their pre-pregnancy weight. Hydration status. Signs to support a diagnosis include decreased skin turgor, dry mucous membranes, decreased urine output, concentrated urine, and a postural drop in blood pressure. Early referral for antenatal booking in of pregnancy is recommended for all women identified with HG. And a psychosocial screening with a validated screening tool like the Edinburgh Depression Score is required for women who present with mild, moderate, or severe nausea, vomiting of pregnancy or HG, above a Puke 24 score of 4, with appropriate referral and follow-up. Patients with mild to moderate nausea and vomiting, where they have a Puke 24 score of 12 or below, where symptoms are not suspicious of HG or any other diagnosis, do not need to be investigated. Thanks. History and physical examination should be directed towards identification of alternate diagnosis. Physical examination should include a full clinical assessment, weight, palpation of the abdomen for abdominal tenderness and signs of peritonism, and an assessment for neck stiffness and signs of raised intracranial pressure, if the history may be suggestive of central nervous system cause for the symptoms. Measurement of beta HCG is of no practical value for the diagnosis or management of HG. The table currently on screen is taken straight from the guidelines and should be utilised for recommended investigations of women with a clinical presentation of NVP or HG. Ketonuria is not associated with either the diagnosis or the severity of HG and is not recommended. A measurement of TSH is only required in women with NVP or HG that's actually unresponsive to treatment, or in those with milder symptoms who have signs or symptoms of thyrotoxicosis. It's also recommended that an ultrasound is performed, if it hasn't been already, to rule out gestational trophoblastic disease or multiple pregnancy, as both increase the incidence of HG. The differential diagnosis for NVP is varied and includes any disorder that can cause these symptoms, which of course can make it challenging. Symptoms such as abdominal pain, fever, headache, and neck stiffness are not features of NVP or HG and suggest an alternative diagnosis. In addition, the vomit of nausea and vomiting of pregnancy is usually non-bilious and non-bloody, although hematemesis, of course, may occur in the context of Mallory-Weiss tears. In women with refractory HG, you should consider investigation for Helicobacter pylori with fecal antigen testing or serology for IgM. The list on the current slide shows possible options, alternate diagnosis, including infection, particularly UTI or gastroenteritis, or surgical causes of nausea and vomiting. Consideration should be applied to rare conditions such as raised intracranial pressure or Addison's disease. Complications of uncontrolled hyperemesis can include malnutrition and loss of muscle mass, weight loss, Mallory-Weiss tears from the constant vomiting, hyponatremia, hypokalemia, venous thromboembolism, abnormal thyroid and liver function, placental dysfunction. That can obviously be associated with an increased risk of small for gestational age babies or preterm birth, preeclampsia, and the increased risk of placental abruption, dehydration, renal failure, dental enamel erosion, and then, of course, the psychosocial impacts and the impact on the family unit. It's unclear if HG is associated with an increased risk of stillbirth. The HER Foundation is currently undertaking further research in this and other areas to ascertain the long-term impacts of HG on both mother and baby. Nausea and vomiting and HG can seriously impact quality of life. The importance of validating and acknowledging physical symptoms on psychosocial distress cannot be overstated. Appropriate and timely referrals can significantly improve maternal health and well-being, decrease maternal stresses in pregnancy and the early postnatal period, and improve long-term health outcomes. Women with HG may require input from a range of health professionals. Some women, as I already mentioned, may choose to have a termination of pregnancy. Treatment options of antiemetics, corticosteroids, and psychological and psychiatric care, as well as offering the option of enteral or parenteral feeding, should be considered before deciding that the only option is termination of pregnancy. All women seeking a termination of pregnancy are to be offered counselling and appropriate and adequate information in order to make that informed choice. Non-pharmacological interventions will be dependent on the women's symptoms and their severity. And it's worth noting that many women view the prescription of ginger as insulting and that their care provider does not believe them or take their symptoms and concerns seriously. It's worth considering prescribing, however, in combination with pyridoxine to be more effective. Advise women to stop taking their multivitamins and iron supplements, but to maintain iodine and folate supplements. Consideration around pharmacological management, including interventions to manage symptoms and associated dysmotility, maintenance of hydration and nutrition, and monitoring and prevention of dose-related side effects and adverse pregnancy and fetal outcomes. In women who are immobile or have additional risk factors for thromboembolism, consider thromboprophylaxis with low molecular weight heparin, unless there are specific contraindications, such as active bleeding. Thromboprophylaxis can be discontinued as activity levels normalize. Medication management should be based on, but not limited to, the PUC24 score and may depend on other factors like blood results and include holistic planning with the woman. As an example, for a woman with mild HG, you might offer pyridoxine 10 to 50 milligrams QID or ginger 200 to 600 milligrams TDS or a combination of both. For moderate nausea and vomiting, a PUC score of 7 to 12, the recommendation is for one of the following taken orally up to 3 times a day. Rest of it, 6.25 to 25 milligrams. Prochlorperazine, 5 milligrams, promethazine, 25 milligrams, or diphenhydramine, 25 to 50 milligrams. I would just note that metoclopramide, 10 milligrams, could be given, but due to the risk of extrapyramidal effects, it should be used as a second-line therapy. It should only be prescribed for short-term use and for a maximum duration of 5 days. It's also important to recommend acid suppression and laxatives for treatment. The other option is ondansetron, 4 to 8 milligrams. This is best for daytime use to minimize sedating antiemetics. It's only to be used prior to 10 weeks gestation if the benefits outweigh the risk. The potential risk of severe dose-related constipation always prescribe laxatives when giving ondansetron. In the case of severe NVP and HG in the outpatient setting, the recommendation for ondansetron is at night with either Restovit and pyridoxine or cyclozine or promethazine or prochlorperazine or metoclopramide. It's also worth considering the use of prednisone as well, 40 to 50 milligrams once a day, and to wean this to 10 to 12.5 milligrams over 7 to 10 days, and then by 2.5 milligrams daily every 3 days to a minimal effective dose, which may be needed to continue until the symptoms completely resolve. The guideline includes potential risks to inform of medication effects and the risk of teratogenicity and practice points to aid informed decision and discussion and decision-making in collaboration with the women. And I think this is really important as a practice point, that quite often women are unaware, and GPs as well are unaware of what the side effects can be. So if there's any particular area of the guideline that you take away, it's probably around medication management and side effects, so that the women can go away informed, so that when she finally gets to her pharmacist and she's told she can't take something, she has the informed knowledge to go and say, well, actually, I am okay to take this. And I've had an informed discussion around the risk to my baby with my GP. IV fluid management is really important to correct dehydration for women with HG. Feedback from the experience of women is that this remains the top priority, and they would rather have it outside of the ED setting. IV fluid should be prescribed for women based on their blood picture and symptoms. IV fluid and electrolyte replacement is an effective treatment for dehydration, electrolyte imbalance, and nausea and vomiting are valuable for both outpatient and inpatient management of the symptoms. Rapid administration is safe for most women, unless, of course, there's a history of cardiac issues. Administration of IV fluid can occur within a variety of settings, and the guideline recommends there should be clear pathways for women to receive intravenous hydration in outpatient settings, including hospital in the home and community care. The requirement for IV hydration and antiemetic therapy adjustment can be provided effectively in ambulatory care settings associated with a reduction in hospital readmission rates. Should symptoms be so severe that enteral or TPN TPN is considered, then of course there would need to be a multidisciplinary approach to care and oversight by an experienced team. Women requiring enteral feeding can actually have care at home, whilst admission to hospital is necessary for women requiring TPN. It's important that when women start either enteral or TPN, we need to realise that they are at high risk of developing refeeding syndrome, and they need to be monitored closely with slow introduction to supplementation. So, the care environment should be one that is women-centred and multidisciplinary. Advice should be provided by the clinician with relevant expertise, irrespective of the care setting. Primary care settings with GPs like yourselves are recommended for women with a PUC24 score equal or less than 12 and no history of other medical conditions. It's recommended that women receiving community care have a clearly documented management plan developed in partnership with the woman. I recommend using the sickness in pregnancy plan, which is in the appendix of the New South Wales guideline. Like the handheld pregnancy record, this plan is held by the woman, but is useful to communicate to members of the treating team. The plan should include advice on how to adjust care if symptoms improve, fluctuate, or deteriorate, instructions on who to contact if symptoms become more severe, and clinical review arrangements on where this is to occur, and ongoing antenatal care requirements. It's also recommended that women receive a copy of appropriate patient education guidance. For women with a PUC score of 13 or over, where the PUC or where it's lower, but there are other concerns, community care treatment may be insufficient. With women in this cohort, care planning must include referral to an obstetrician or an experienced physician via an established pathway. At the Royal Hospital for Women, these pathways can be found via the South Eastern Sydney Health Pathways. There's an HG pathway available to support patient management, and how and when to refer is on there. The pathways can be accessed by the link or the QR code that you can see there. These pathways are for healthcare professionals and not the general public. Where a thorough assessment identifies a woman is not medically compromised and does not require immediate care, but would benefit from IV fluid rehydration and multidisciplinary care within 24 to 48 hours, GPs will be able to refer to the Royal Hospital for Women Pregnancy Day Stay Unit. You'll be required to fax a copy of your referral to the Pregnancy Day Stay Unit, requesting a review of the woman in Pregnancy Day Stay for treatment of HG and include a summary of medical and pregnancy history and reason for referral. Any existing care plans should be included. The Pregnancy Day Stay midwife will contact the woman, triage appropriately, and arrange an appointment for the woman to be seen. Please ensure when you refer that the woman is given a referral letter. She will not be seen in Pregnancy Day Stay without one and will be directed back to you or to the ED. This clear clinical pathway is required to enable women to access timely care and to bypass standard triage processes and to reduce unnecessary ED presentations. However, where women are medically compromised, of course, they should be transferred to an ED. Where women are booked to have GP shared care, it's recommended that their antenatal care appointments will continue with collaborative care for their HG management. In women with persistent nausea and vomiting or HG beyond 16 weeks, fetal growth surveillance in the 3rd trimester of pregnancy is recommended. It's known that HG impacts a woman's psychological and emotional well-being and disrupts the family unit. Women who experience these conditions are more likely to describe high levels of post-traumatic stress syndrome and associated negative outcomes. It's important to monitor for postnatal depression in this particular cohort of women. Ensure referral and link in with local and cultural community-based services. When looking at planning a future pregnancy, research findings suggest that the recurrence risk is high, but it's difficult to estimate as women with severe symptoms may be unwilling to consider a further pregnancy. Women who experience severe NVP or HG will benefit from preconception support, counselling, and early or preemptive treatment with antiemetic therapy. Literature supports that early intervention provides better outcomes when compared to those women commencing treatment later in their pregnancy. It's therefore recommended that the first comprehensive antenatal visit in subsequent pregnancies occurs as early as possible in the first trimester. This will enable a comprehensive medical and pregnancy history and psychosocial screening to be undertaken, as well as early referral to the multidisciplinary team. Additionally, women may benefit from early dietary and lifestyle changes, either prior to or at the commencement of symptoms. In conclusion, HG is a significant, debilitating illness affecting both the physical and mental aspects of women's lives. Initiating an appropriate care plan earlier will vastly improve outcomes. Assess using the PUC 24 scoring system, exclude alternative diagnosis, facilitate referrals early as required, and please familiarise yourselves with the New South Wales guidelines and medication protocols. And the other thing I will say is please use the health pathways. A couple of resources of use. The New South Wales Health Nausea and Vomiting and HG resource page, and the New South Wales Mother Safe Medication Advice Line. Both have resources there for healthcare professionals and for the general public. And in terms of nausea and vomiting of pregnancy, there are some really useful resources on there that can help clinicians and women to be able to manage their to get symptom support and to aid them in their decision making around their care. That's it from me.
Joanna, we have an online question. Can I put it to you? Other than the extrapyramidal side effects, what is the reason for only 5 days of metoclopramide?
And that's a great question. And I would answer it by saying, because Prof. Lowe tells us that's what we have to do. But there is strong, that's the exact reason for why. It is around those side effects. That's why. And I think a lot of women do take it for longer, but they need to understand that if they are taking it for longer, it's with risk of those side effects. So, yeah.
The other question coming online is there a specific phone number for GPs to call for urgent referral for hyperemesis, or should they refer through the emergency department?
An urgent referral, my assumption to that would be where there's a patient that you're reviewing that you have concerns about their well-being and that they're hemodynamically unstable. And if that's the case, then they really should be going through the ED department. If you review them and you feel that they can wait 24 to 48 hours to be seen, then you would follow the pathway through the pregnancy day stay unit.
Where do we find that pathways?
So on the health pathways web page, and I think it should be, you should have a link to it in your books, but it's a great, it should be, as one of my slides, healthcare pathways. It's a great resource, not just for HG, but for all, yeah, for everything. Yeah. Yeah.
Thank you for your talk. I would like to ask you, in your experience, is HG as common as in future pregnancy, like the first pregnancy?
So the evidence is unclear in future pregnancy. So if a woman has experienced HG in her first pregnancy, there's some research being done currently to suggest that there is a genetic link. And so if you do have it in your first pregnancy, there's definitely a high chance that you will suffer it again. And certainly anecdotally from the women I speak to, they most often get it again. Sometimes they don't have it as badly, but most of the time that's because they have an awareness of how horrific their first experience was, that they seek treatment early. The other reason that we're not sure just how prevalent it is in ongoing pregnancies is because, quite frankly, a lot of women choose never to have a pregnancy ever again. So that in itself is difficult to get the numbers. But yeah, certainly there's some evidence of a genetic link.
Is there anything that we can do to protect the women's teeth if they're vomiting?
I would say send them to the dentist.
Okay, so there's no
Dental care in their pregnancy as a requirement for their care, just to make sure that their teeth are healthy. So yeah, get them to the dentist.
Thank you, Joanna, for bringing all of that information to us today, and particularly all the referral pathways and interventions that we can use to make a difference to our patients' outcome.
Thank you. Thanks for having me.
Everybody switched back on and ready to go again? So our last presenter for the day is Katy Hunt. Katy's a clinical midwife consultant and international board certified lactation consultant at the Royal Hospital for Women. She's been working on the postnatal ward since 2001. She's learnt from Joy Heads, the clinical nurse consultant in lactation, OAM pioneer and expert in the lactation community. Katy's cared for and supported new mothers with their breastfeeding goals. IBCLC certified since 2008, as well as having practical first-hand experience as a mother of 2 boys. Katy presents weekly breastfeeding classes to pregnant women and new parents and can be found either talking, teaching or observing breastfeeding to women and staff. The Royal Hospital for Women lactation consultant receives calls from across the district and sometimes across the state from GPs, midwives and parents. Please welcome Katy to speak to us this afternoon.
I'm telling myself too. I love talking about breastfeeding. I could talk about it all day, and I do. So you asked me, thank you for having me anyway, and I was told you wanted to hear some quick hacks on how to manage breastfeeding, and I've got that for you. And I've also got some updates on mastitis, because the Academy of Breastfeeding Medicine released a new protocol which has got some new words in it that even I'm thinking, oh, I don't think I'm going to say that. But anyway, here's some images to get you excited about breastfeeding, like the first 2,000 days, BFHI. Breastfeeding in the hospital, we were just lamenting before that we didn't get a lot of breastfeeding education. Even myself, when doing my midwifery, I got one lecture on breastfeeding, and here I find myself a lactation consultant. And so that's because there's not an investment in breastfeeding, there's not education, it's not consistent across Australia. We don't even report the same. We don't even gather data the same. And it's about time we did. And the Australian National Breastfeeding Strategy is trying to fix that, but it's just been a little bit of a slow burn. So anyway, thank you for letting me say that. And thank you for being interested in breastfeeding and helping our women achieve their goals. So today's objectives: describe 2 or more policies relevant to BFHI maternity hospital. So our women are coming here to a BFHI hospital. I'll tell you what that is. The next one is discuss 2 ways to support a pregnant woman or mother with concerns about her ability to breastfeed, and describe 2 factors that indicate referral to antenatal lactation clinic. I'll tell you what that is, and explain the basics of breastfeeding and troubleshoot common concerns in the first weeks, and explain how to refer a mother experiencing lactation issues. I have a referral. My phone number's on the front of those blue books that go out. 4,000 births a year. You can imagine how many phone calls I get. So what does BFHI stand for? Does anyone know? Sometimes I put that to the medical students and I'm surprised at the answers. And the last time I put it up, I put the answer up at the same time. Yep. I love that you said that, breastfeeding. Yes, it should be saying that. But I'll give you a couple of breastfeeding for health initiative, breastfeeding friendly hospital initiative, or is it breastfeeding in healthcare initiative, or is it baby friendly health initiative? It is in fact the baby friendly health initiative. And that's because the policies and practices in a BFHI hospital aren't just about breastfeeding. They're about keeping mothers and babies together. The practices are bigger than just breastfeeding. The physiological evidence for skin to skin, for example, isn't just a nice thing to do. It's a necessary thing to do for the well-being of the mother and the baby. Come to that in a second. You would be forgiven if you said baby-friendly hospital initiative, because it actually comes from the World Health Organization, the baby-friendly hospital initiative, to embed practices in the hospital and the healthcare facility that promote and support breastfeeding, so that, you know, the kind of policies and things that we just have that we don't think about. It's kind of like, compare it to every baby gets vitamin K when they're born. Every baby should get skin to skin when it's born, unless it's a medical reason why they shouldn't have one. It's launched in 1991 following the ANSC Declaration. That's an old document that talks about the benefits of breastfeeding and how it's a biological norm, and there should be investment into that. And sustainable, this is bigger. This is the BFHI document that really shook things up for BFHI. And global nutrition targets, this is a World Health trend to make sure breastfeeding is important. And in a country like Australia, it's just as important. So, and the WHO code. Does everyone know what the WHO code is? The International Code for the Marketing of Breast Milk Substitutes. It's something that is, I'm going to talk about. So changed. So if you said, the Royal Hospital, sorry, I'll just backtrack a bit. The Royal Hospital for Women's been accredited since 1999. And the women that are coming here know this is a BFHI hospital. And we mentioned Joy in my introduction. Joy Heads, when she started here, she pioneered the implementation of BFHI in this hospital, and she taught me, and she's forgotten more things than I know about breastfeeding. And back then it was said that if you want to formula feed, you must bring your own into hospital. That's not the case now. Now the case is it's not just about breastfeeding, it's about safe infant feeding. So having those conversations about keeping you and your baby safe, which is a good thing. So we've had a real overhaul. These 10 steps, which is what goes through the hospital system now and all BFHI hospitals, is bigger than breastfeeding. It's keeping mothers and babies together. If they need to have formula, they have it. And we're not anti-formula. That's not true. We are not anti-formula. We are sensible formula use. So let me talk about that WHO code I mentioned before. So if anyone hasn't heard of the WHO code, it's not anti-formula. See those old pictures there? Breast milk substitute companies, even when I was at uni, we were told about these awful marketing practices of promoting it through using doctors and midwives and health professionals saying you need to use this product. And then these vulnerable mothers were using the product. Then they were stuck formula feeding their babies because their milk dried up, and then they had to keep buying the product. And these were abhorrent marketing practices. And this is in the 1981, this International Code of Marketing of Breast Milk Substitutes was born. And I mean, think about it, in a time, not now, where there's no Instagram, there's no Facebook, there's no anything like that. These people got this brought to the attention and the WHO code came about. Now it's changed. It is about making sure that the WHO code protects mothers and babies and the safe distribution of breast milk substitutes. We still need them, right? So the WHO code protects human rights. It makes sure that women who are making decisions about their mothers, about their babies and their bodies, it's free from coercion. I'll get you to have a look at that big one there. How Target figured out a teenage girl was pregnant before her father did. Has anyone seen this article before? Yeah. It's about how the algorithms, these sophisticated algorithms on Google and that can track the activities and find people and target them. So marketing and advertising is changed. It's changed a lot. And the World Health Organization and the WHO Code, actually the World Health Assembly, this report I'm talking about here, this green picture there, it's a $555 billion market. And they're saying that this is really bad. This is why I'm telling you this, is because when our mothers come through being pregnant and then postnatal, what are they doing? They're Googling. They're Googling away. And they are going on these parenting platforms and baby clubs, and they are exposed to these marketing practices. And what we can do as health professionals is say, look on the Australian Breastfeeding Association website. If you want to Google or you want to look something up yourself, look there. There is a code on the back of it. Go and look at Tricillian or Caratani or one of those, because they don't have any emotional, they don't have any money investment in what they're saying. It is evidence-based, and it's safe for them to look for that information there. Okay. So the 10 steps, just quickly, have a policy, comply with the code, and ongoing monitoring data. And that's good. Remember I said there's no national uniform way of collecting the data. BFHI hospitals all collect it the same. They collect how many women initiate breastfeeding and how many women are still exclusively breastfeeding on discharge and when they are following up. And if you're curious, it's 97% of women initiate breastfeeding. So that's everyone. And we talk about the others 10 steps of different things, like talk about it in pregnancy, make sure they have skin to skin, make sure they initiate it within the first hour, make sure they're shown lots of different things, avoid teats and dummies and discharge planning. I'll just go through these now. So lactation services at the Royal is myself and Sarah. And these discussions about breastfeeding can be done antenatally. Let me tell you, it's a lot easier to talk about breastfeeding without a screaming baby in your lap. So many times if a woman expresses a concern or you notice a very real concern, those conversations are better had before the baby's born. It's never too early. You think about it, they're always so focused on how the baby's going to be born. How's it going to be born? Am I going to have an epidural? Is it going to hurt? Let's talk about some breastfeeding before the baby's born. So our lactation clinic, I have a clinic here on the outpatients department on the first and the third Wednesday of the month. And I welcome referrals. You can call the outpatient department and ask for them to make her an appointment. There's only, well, I see 6 ladies, 12 a month. And so I have caught up a bit, but sometimes I have to wait a long time. Sometimes they forget their appointments. I'm happy for mothers to call me and tell me their concerns. Sometimes it's just sometimes just a conversation, and sometimes it's a face-to-face chat, and it can be really helpful. So a word on breast surgery. Well, obviously, if a lady's had breast reduction, I definitely need to talk to them, because a breast reduction is more likely to cause insufficient lactation and all the other things that are wrapped up in having your breasts disfigured. Well, they probably think they look better, but they've been under an enormous augment. But other things like high BMI, dare I say, advanced maternal age in this catchment area, IVF, PCOS and hypothyroidism all impact lactation, right? And I welcome those conversations with these ladies so that I can offer them not unlike a birthing plan, breastfeeding plan. You know, what can you do? What are your options? Where are the support networks around? So, there it is. So breast surgery includes previous surgery for breast cancer, lumpectomy, breast reduction, and breast augmentation. Australia has overtaken the US for most cosmetic procedures per capita. Did you know that? And Australia has done, in the last think last year, 2022, 20,000 breast augmentations. I think that might be my core business here. So to say that they don't impact breastfeeding is a lie. They're much more represented in nipple damage, in engorgement problems, in mastitis. 30% of them are having trouble. Well, nearly everyone's having trouble in the beginning, feels like it, but they are overrepresented in problems. And it's important that they understand the impact that implant has on lactogenesis too. Okay, so not all breast surgeries, be they augments or reductions, are performed in Australia as well. I had a lady who had fat cells from her buttocks placed in her breasts. That was done in Singapore. And I have ladies that have their breast augmentations done in Brazil, where they cut around the areola and have a little scar around the areola. And those ladies will often have some changes in the sense in their nerve area underneath. They actually can't feel anything underneath the breast. And some ladies, I haven't seen it very often, but sometimes the scar is under the arm, is paraxilla. Sometimes the implant is placed in front of the muscle. They have much more discomfort with engorgement, but most of it's subpectoral. So it's trying to figure out when I meet them, why did you get breast implants in the first place? Most of the time they go, oh, you know, I just wanted a better line, you know, I just wanted bigger. But sometimes there's something there. Sometimes I go, oh, well, why did you get, well, they were just really weird shaped. They were really skinny and, oh, that's breast hyperplasia. That's a good reason to have a conversation. And I have to make sure that the reason they had their breast implants wasn't because of that, because they're going to be disappointed. So then I think, well, breast hyperplasia is the next one. No increase. I don't know if no increase in size by the third trimester. I'm not sure if the evidence is stacking up on that one, but it does suggest breast hyperplasia. And it does suggest, well, why didn't you notice there was any breast changes? Was there really no breast changes, or have we got something else going on here? Are you anxious? Are you not noticing your body? And definitely breast hyperplasia. So previous traumatic breast history, breastfeeding history, that's a conversation. And I have to tell you, like, if I can offer, if you're doing it, they don't want to hear, oh, that worked or that didn't work. They just want to hear, oh, that must have been really hard. They nearly always blame themselves and they nearly always catastrophize about it because it's how it made you feel when you were breastfeeding. And the last thing is nipple inversion. We as midwives like to be upbeat and positive, you know, yes, you'll be able to breastfeed even though you've got inverted nipples, but inverted nipples make such an impact when the baby is trying to establish breastfeeding. In the establishment of breastfeeding, the baby's innate need to seek out the breast and establish breastfeeding is impacted by the inverted nipples. And inverted nipples, as you know, can be grade 1, 2, or 3. The grade 3, oh my goodness, they are trouble. It's very useful to have a conversation before the baby's born, wondering why that baby doesn't go on. Okay. So as I said, you can call me directly with the number that's on that white piece of paper on the yellow card. You can tell the women to call me if they want to talk to me. I welcome their conversations and their questions. This annoying little half white page, midwives hate it, is stapled to the yellow card. But look, it's got those, the first line says breastfeeding, breastfeeding the normal way to feed your baby, the benefits, list the benefits and everything like that. In all my time, I've had one woman that went, not interested, just one. Everyone else was, oh, I didn't know that. Oh, I didn't know. And it might be, you know, you might not feel like having that conversation, the benefits of breastfeeding, or you might, but isn't it, you know, we're in a position of trust and credibility. Yeah, plug it. Yeah, breastfeeding is really great. You know, you should do it. I'm sure you do. But when you say it, when you really say it, they listen. They go, oh, my doctor said I should breastfeed. Well, you should. So the risk of not breastfeeding is probably, some people have been saying that. It's just about that informed decision, the risks and benefits, right? We know on the top page there, the risks of women who breastfeed, who don't breastfeed. There's the SIDS, there's the increased risk of obesity. And this is an impact on, remember the first 2,000 days? It's on that too. It's important that we encourage breastfeeding. We set them up to have the choice to breastfeed. They've got no choice if we don't do the right things from the get-go. So the other thing, women who, the worst breastfeeders is our Aboriginal women. Their statistics are pretty poor. And the other one is the CALD women, the called women. So Galu and I work together and we do a group where I present with the interpreter there. And as a network, as a group, they hear from me, they see me, they identify me as the lactation consultant. And we think that that's helping. So that's helpful as well. They're less likely to engage with those support groups and face-to-face. So we feel that it's a good idea. So there's that little leaflet there. It's also got the classes on. You know, I said I do classes once a week as well. You can find the details on there. We book through Try Booking. It's all online. It is paper, but once they get it online, that'll be all right. And they can find the ABA on there. And it does go through those 10 steps that I mentioned before on the back of it. So that's my class every Thursday morning, 10:30 till 12. And partners, you know, we've been online with since COVID and it's working really well, I think. When I look at my numbers, they're pretty much the same pre-COVID, during COVID. Yay me. And then evening one, when I used to get everybody here on a Tuesday night was my biggest ticket. Like this place was full on Tuesday night. So, and they come from the private. So isn't that good? I think my predecessor built that reputation, but that's okay. What else have we got? That's just the website is being upgraded, which is exciting, but you can book through the website. So we were saying outside, women don't want paper. There's lots of stuff on the website now. They can go straight onto the website, book the classes on the website. Quick hacks, here you go. Our quick hacks will be breast changes and milk volume in the first week, expressing and breast pumps, making more milk, and settling breastfeeding babies. That is a myth that breastfed babies don't sleep as well as formula-fed babies. That is a myth. It's a lie. So here we go. So true or false? Babies breastfeed as soon as they're born. True, they do. Babies are born with innate feeding cues and they just know what to do. That first hour after birth, Widstrom's 9 stages where the baby just follows its feeding cues, amazing. Most mothers don't have milk right away. That is true, but they have something better. It's called colostrum. Colostrum, the first milk, the most nutritious thing a human will consume in their life. And sometimes mothers think, oh, I haven't got any milk. Mothers will think, you know, because they go home really early now. They might ring you and go, I haven't got any milk. Oh, okay. It's 24 hours since your baby was born. That's normal, right? And we, the midwives on the ward, we say, oh, what, low supply on day 2? That's just not a thing. So I quite like that saying. The mothers kind of diffuse quite quickly on that one. See, you did know this. Who's seen these? This is called a haka. This is the new thing, the new pump on the block. This is not a breast pump. If mothers say, you know, I've got there's nothing coming out of my haka, or yeah, I've got a breast pump, I've got a haka. No, it's not a breast pump. It's this silicone soft device. It's useful, but it's not a breast pump. There's this crazy woman on YouTube that puts the haka on one side and she puts the breast pump on the other, and she goes, my haka is so good, it got the same amount with my Medela pump and the haka on this side. And I just go, no. The reason you've got milk in the haka is because you put the Medela pump on. If you put a baby on one side and the haka on the other, you'll get some milk, but it won't work on its own. If you put the haka on by itself, I'm sorry, it won't work. What does it say?
Okay, breast pump. So it just literally sits there.
Correct. That's my bugbear.
You're feeding and you collect.
Yeah, it can be a really helpful tool. I was just asked, but it says it's a breast pump on the packet. And it's a useful tool when you are breastfeeding and you want to perhaps gently build a stockpile without interfering with your breastfeeding pattern or breastfeeding chaos, which is normally what happens. It's a great way to stockpile a little bit of breast milk so you've got some spare just in case. I have had more than one phone call where women have called me and go, I think I've got an oversupply. And I go, why is that? And they say, well, when I breastfeed and put my haka on, I get 60 mils. So I say, take your haka off because your body thinks you've got twins. Easy. So you have to get a breast pump. That's false. Some ladies will not even pick up a breast pump. They're too busy feeding their babies and responding to their cues and doing what they should. But they've got this fascination with antenatal expressing. Have you heard that? Has anyone asked you that? Antenatal expressing is new. It's the new thing. Well, 2015. And they also have it on the Australian Breastfeeding Association website, how to do it and the evidence for it. And they use the DAME study. DAME studies diabetes, antenatal something, DAME study, but women in pregnancy with diabetes. And we show them from 36 weeks how to hand express. And they argue, oh, it's going to give me more milk or it's going to give me a extra bit of milk when the baby's born. And it's more about the practice, the experience of handling your breasts and being confident going into the breastfeeding. And what a buzz of going, oh gosh, I've got milk. My baby's not even here and I've got milk. So it's more the experience that we encourage. There's no evidence that it induces premature labor, just to be honest, just to be reassuring there. Booby biscuits are great. That's false. They are overpriced, sugary, nutrient empty snacks. And it's an interesting study on the main component is brewer's yeast. And there's an interesting study on how useless that is. So if you put it in, I don't know, why would you put it in booby bickies? But anyway, that doesn't work. What makes milk? Babies make milk. Breastfeeding is natural. Mothers and babies stay together 24/7. Yes, mothers and babies stay together 24/7, but is a Caesar, a forceps, a ventouse, PBH, is that normal? No. No wonder they have problems. Foundation to successful breastfeeding is getting the right latch. Yes. Now go home. You know everything. So the frequency of feeding and the duration at which they feed is entirely baby-led, and it just works when you get the right latch. Okay. How do you know they got the right latch? Because the nipples aren't broken. We were saying before, if a lady comes in with the nipples falling off, that is a red flag. That is a go get help, stop everything, maybe put the haka on, that's okay. Put a breast pump on and get off to a lactation consultant or the child and family health nurse. You need help. Damaged nipples are never okay, never. Cluster feeding is normal. When do you say cluster feeding is normal? I always ask more questions. When is this happening? What does a baby look like when that's happening? Does it happen all day, every day, or does it happen just a small part of the day? I think it's an amber flag. I think it's trouble. I need to ask more questions when someone says, my baby's cluster feeding. I've seen babies come off the breast that are just too tired to keep going. They fall asleep before they're even full, and then they wake up short time later, still hungry and never quite catching up, never quite putting on the weight. And mother thinks, oh, this is normal. And that's a worry. But, you know, you look at the baby, you look at the mother. Is she exhausted? Is she tired? Yes, that's a red flag. Is the baby too lethargic? Doesn't it test well? Is it tired? Has it done many poos and wees? That's a problem. So you need to encourage her. You need to feed this baby and we'll work together to get that milk up, get to where you need to be. You know how Andrew was talking about the late preterms? They are the bane of my life as well, those ones. Between 36 and 38 weeks, they've like the great pretenders. They look like they're doing a great job and then they lose weight and then they do that cluster feeding where they just fall off the perch. Anyway, hope you found that helpful. Breastfeeding hurts, suck it up. No, painful latch, persistent pains, the main reason people stop breastfeeding. It is up there. Why did you stop breastfeeding? Didn't have enough milk. And the number 2 is, why did you stop breastfeeding? Because it hurt. So they're the main reasons people stop. Dummies and bottles. This is a step in the 10-step successful breastfeeding. Research suggests that dummies may, I use that word a lot, may, because the research is like, oh, yes, it is, maybe it's not. But if you use your brain, it's like the baby, when you're establishing breastfeeding, we follow the baby's cues. Oh, baby wants to feed. If it's lying there wrapped up like a burrito with a dummy in its mouth, it's not going to give you any cues. And also, if I can offer, mothers that use dummies before their babies have established breastfeeding are practicing using these dummies, right? And we use dummies, we were using dummies in newborn care to increase the strength of the baby's suck. If a term robust baby's born with these lovely big buccal pads and we give them a dummy, it's like boot camp for their sucking. Then the mothers will say, my nipples hurt. No wonder. Their babies have got really strong sucks. So we're not anti-formula, just formula wary. So if someone says, I should bring my own formula in. No, you don't need to bring your own formula in. We have it in the hospital. It's just for your interest's sake. In COVID, and we don't use sterilizing. We don't sterilize bottles and teats anymore. So it's a pre-pack thing. And when the mothers ask for formula, they get it. But my midwives and everyone in the hospital knows that it's the volume that's important in the establishment of breastfeeding. So just in a nutshell, they don't need to bring their own formula in unless they've done their Google homework and they want to use, like, I don't know, organic camel milk or something like that. Sure, they can bring their own formula in. Quick breastfeeding checklist. Babies feed 8 to 12 times a day. They have 4 to 6 pale soaked nappies, 4 to 6 soft runny poos. If they're putting it out, they're getting it in. And breasts can be full and uncomfortable first thing in the morning and feel soft and empty in the evening. So some ladies will say, I haven't got any milk in the afternoon. It's normal. And nipples are tender but intact. Caring for a newborn baby is hard work, and babies should be feeding at night. Oh, how they're obsessed with the sleep. They're obsessed, aren't they? They're obsessed with getting sleep. Like, your sleeping days are over. Like, there's a really good one, Purple Crying. Oh, and Howard Chilton. You have to encourage your mothers to read Howard Chilton, Baby on Board. Yeah. And Purple Crying is another doctor that talks about uncontrolled crying. Purple is an acronym for periods of uncontrolled, resisting, soothing. I forget the rest of it, but it does explain that babies are meant to cry. We're not meant to fix it. We're just to go, there. Let mummy walk this painful journey with you. It'll all be over soon, like when you're 18. So what do you know? Of course you know. Like when Sarah on there, she goes, I don't know anything about breastfeeding, Katy. And I said, of course you do. You're a doctor. You know about breastfeeding. She goes, no, I really don't. And I said, yes, you do. You know about oxytocin, prolactin. You know about lactogenesis 2 and getting the right latch. You know all these things. She said, yeah, I do. And I thought, maybe you guys feel like I do about working in birthing. What's not Sarah? Siobhan always says to me, you'll be fine. You know what to do. You know about the presenting part and, bright lie and contracting the palps. You'll be fine. Maybe that's how you feel. So remember oxytocin. Oxytocin makes you feel good. Oxytocin makes the milk come. When women are stressed and all consumed in their woes and have got other stuff going on, oxytocin doesn't work. And that can be a problem with breastfeeding. So when they're looking at you and they're exhausted, we've got a problem. So prolactin, that's the other hormone to produce milk, and the prolactin level rises straight after the breast is emptied. And this is the whole cluster feeding theory. As long as the baby's drained the breast, it shoots up more levels of prolactin. The baby feeds again in a short space of time, prolactin level goes up, and this increases the milk production. Domperidone. Did you know domperidone is on the therapeutic guidelines now? Does everyone feel comfortable prescribing domperidone? Domperidone is now, thankfully, on the therapeutic guidelines. I was asked just this year, can I write a cheat sheet for a doctor so that they felt comfortable prescribing domperidone? Because as you know, It's an off-label use. Well, now, thankfully, it's on the therapeutic guidelines. The boss of all things, domperidone, I can't even say his name, and Lisa Amir, they have some more research coming up on that about the dose. The Royal Hospital for Women's changed the dose. We were 10 milligrams, and if you didn't see a result after 3 or 4 weeks, you could increase it to 20 to 30 milligrams. But the evidence is sketchy on whether that was helping or not. If you want to prescribe that, you can, from the therapeutic guidelines says, but our policy's taken it off because we just didn't feel comfortable with the evidence that we had to leave it on there. Interesting, huh? So the Blue Book, as I said, not my numbers on the top left-hand corner, 4,000 births a year, got a lot of questions. And I put these annoying fact sheets in. They're annoying because it's paper, right? And they go in the Blue Book, and they've got mastitis checklist, which I'll go through in a minute. Mastitis, they've got the increasing your supply, and in that's got the dosing of domperidone, expressing milk, how to store it in the fridge and all that. So, but just to remind you, that little bad boy there from the Australian Breastfeeding Association is really good. It's got how long it's good in the fridge for, expressing, and lots of information in there. I really like it. Okay, and the Royal Hospital for Women website finally has all those fact sheets on the website. So breastfeeding support. When mothers give birth at the Royal, they can access Sarah and me directly, but we're trying to make it more useful so we can see everybody and appropriately, right? And so midwives, they have to do so much education in a BFHI hospital. They have to do 8 hours, and they have to do the 20 core competencies. So they're an excellent resource for troubleshooting all things breastfeeding. But when things get a little bit more tricky, like your breast augmentations and breast reductions, then Sarah and I will be involved. But on the postnatal ward, Sarah's involved. This is Sarah. So women who birth at the Royal Hospital for Women, if they come to you and they say, I really want to see a lactation consultant, and they can't afford to pay, what, $300 for a private LC, we can see them up to about 3 weeks. And the reason it's 3 weeks is because that's like the ultimate time to nut out those attachment problems. You know, that's the best time to get things under control. And we respond in business hours. Okay, that's me. So remember I said about accessing websites, just quickly go through them there. So Australian Breastfeeding Association. You can also join the professional aspects of the ABA, and they do interesting webinars and things like that, and you can get breastfeeding hours if you wish. And Drusillin and Karitani, Mother Safe, medications in pregnancy. We talked about that before, you know, Mother Safe. They're not part of the Royal, but they're based here, I believe. Is that right? I think so. Okay, that's them. Let's do mastitis. Now, I'm never going, I don't think I'll ever say that phlegmon word. I don't know if I want to say that. But women are going to keep saying, I've got a blocked duct, I've got a blocked duct. But they don't, do they? They don't have a blocked duct. They're having ductal narrowing. They've got an inflammatory response. But when they massage the breast, they exacerbate the problem. And so they're going on the internet going, massage the breast, make sure you feed the baby, drain the breast. These things are thought to be counterproductive. We need to reduce the inflammation. So cold compresses, leaning back, reverse pressure softening. And there's the new policy even talks about, it also talks about doing that, what's that massage? That massage with the lymphatic massage as well. And a lot of mothers, tell me if I'm wrong, are going to have therapeutic ultrasound for mastitis. Yeah. And this new protocol acknowledges where it's useful in that. So the ductal narrowing, the inflammatory response, the feedback inhibitor of lactation, all exacerbates this, this very inflammatory response to the breast when it's lactating. And just removing the milk isn't always the problem, isn't always the first action. yes, you keep on breastfeeding. My God, of course you keep on breastfeeding. But being mindful, the ductal narrowing is going on. Yes, the supply is going to go down. The body needs to do that. Yes, you need to keep feeding the baby. If she can comfortably feed the baby, keep feeding the baby. And as you know, the antibiotics that we prescribe isn't bad for babies. Like you can still prescribe flucloxacillin for mastitis. And they talk about the microbiome as well. And they're saying that it's true, isn't it? Women who've had traumatic birth and this and that also get mastitis. You know, they don't just get one thing, they get everything. And yes, it can be the latch, like inconsistent milk removal, but they're not blaming nipple damage so much anymore, because the nipple damage is more in the context of not emptying the breast, not watching what's going on, being tired. Babies might have a, I don't know, tongue tie, things like that. Plugging. Yeah, it's not physiological possible for a single duct to be blocked. The area that tender is inflamed by lymphatic congestion and alveolar edema and can resolve spontaneously. This is why we don't tell them to massage anymore. And this is why the therapeutic ultrasound is helpful, because they've got this idea. They're not telling the mothers to massage and drain the breast. They're telling them the right thing. No, cold compresses, leave them alone. If you can feed the baby, keep feeding the baby. And I think the mothers that say, oh yeah, I massage the lump out, probably fed the baby and reduced that pressure in the breast and made it feel like it was unblocked. So what do you do if someone's got, I don't think I could say that word, phlegmon. It's fluid collection, but it's not an abscess. An abscess is a collection of fluid that needs to be drained by ultrasound. And so if you send someone in, they go through A&E. Yes, they go through A&E, and then they call our doctors across, they do the septic workup, and then they call me to come and make sure they're feeding properly. I've given them all the right advice, and that they've had a breast milk culture, and I've got to chase that up as well. And the breast milk culture is just to make sure that the antibiotics is not resistant. So anyway, have a look at that protocol, that mastitis protocol, because it's very interesting. And it does mention lecithin. Lecithin is thought to help with those horrible milk plug, the blebs, they call them, milk blebs, a little white spot on the tip of the nipple. They're so painful. And they say, no, don't unsheath them, unroof them, roofing, don't unroof them. But the soy lecithin is thought to reduce the thickness of the milk. And yeah, I had a speaker just recently from a physio clinic talking about therapeutic ultrasound and the part it plays in mastitis. And a lot of people are managing their mastitis before they come to hospital. They're not getting into hospital, they're managing it well. I did see a woman with mastitis that had breast implants, and it was disgusting. It must have been the biofilms had gone right through her body, and we had to remove the breast implants, and she had 2 drains, and it was the worst thing I've ever seen. So yeah, they do impact. This poor woman here was told to stop breastfeeding, and she got necrosis, and frequent milk removal. Some people are a bit slow to catch on, but you don't do that. You just feed the baby as the demand. And if you get full and uncomfortable, you want to put the pump on, then you should. So our policies changed a little bit. That's it there. They're in your book. And as I said, refer Prince of Wales A&E. And if they require admission, if they're before 6 weeks, they come to the postnatal ward, and if they're older, they go to the Macquarie ward or somewhere on the Prince of Wales Hospital. And I still get the call to go and see them. And they can, the breast centre accept referrals for ultrasounds. The GP can refer for ultrasound to the breast clinic. And if you have any other concerns about them, I saw a woman this week who had multiple cysts in her breast, like multiple cysts, like some of them were 20 mils of collection, and she just gave birth, and I was like, oh, how's this going to go? She seems to be going all right, but she does have this persistent firmness to her breast, and she's having trouble with the latch. So we'll see how we go with her. Was that helpful? Any questions?
We have some online questions.
Awesome.
So the first question
I've got for you is, if mothers haven't weaned a child before they have their next child, do they still get colostrum?
They do. there's this magical, no, it's not magical. The body does change that milk to colostrum, and some mothers will report that the older child, tandem feeding they call it, the older child will refuse, and the newborn will definitely get that colostrum. So yes.
Question that's a bit topical to the domperidone question is apparently the MHRA has put warnings on the use of it because of cardiac risk. The TGA says to have care in its use. And one of our doctors in our online audience has had medico-legal advice from their insurer not to use it. So what do they do when the patient comes in with instructions from the lactation consultant to get it?
Gosh, yeah. Well, it's the QT interval they talk about, isn't it? So, and my understanding is that that is significant in the people that are using domperidone for the use it's intended for. But in healthy, well women, there's a study that shows that women that they tested the QT interval, they did them echocardiograms that had domperidone for the use of what we're using it for, and they didn't have any changes. They were fine. So I don't know.
I suppose there's a problem with people for whom you don't know there's a long QT.
Yeah. But I guess though that it's because it's an off-label use, isn't it? That's the thing. It's an off-label use, and until they say, yeah, you can use it for that, we can't. I understand that. I can't answer that question.
Interesting question to bring up in a forum like this. Yeah.
Off-label use.
Any questions?
Can't remember. It's a couple of, I think you can use it for like a month, but you can actually use it indefinitely if the woman is, as long as she wants, like, you know, longer than that. One of the doctors up here is using it and her babies are 8 months old. As long as the symptoms aren't bothering the lady, I believe the symptoms are very underreported. They're so desperate to get that milk that they're putting up with the side effects, you know, the gastrointestinal upset, headaches, dry mouth, things like that. And they're just putting up with it. And the bigger the dose, the more side effects are. So that's just something to think about.
Ask about tongue tie. It sort of was in or out or whatever.
Tongue tie.
It released, yeah.
Asking that question. Isn't tongue tie the most fashionable thing at the moment? Our statistics are that it's about 4% of babies, and of those, half of those 4% will cause a problem with breastfeeding. Some of them, it just looks like a tongue tie and they don't have any problems, and some of them, the other half, it actually does. And there's no tongue tie clinics in Sydney. They are expensive, the ones that are, and our amazing Dr. Smythe is cutting them on in my BSU, breastfeeding support unit. And what you can do, we are gathering data on that. We've got about 180 babies. We've snipped the tongue within the first 3 weeks, and we've had some really good outcomes, you know, and we've seen one reattach, but the rest have all been good. And if you want to send someone back to us, feel free, like that's okay, the first 3 weeks. Otherwise, these clinics are, there's about 4 I know of within Cooey of here. And yeah, it can really make a mother and baby lives a lot better. They're heard, they're listened to, and it can make a difference in a lot of them. Not all of them, but a lot of them, it can make a real difference releasing the tongue. And it's just a release, it's not a cut. Yeah.
You express breast milk before the baby is born. Do you not tend to lose the colostrum?
The question is, if you express breast milk before the baby's born, do you not lose colostrum? No, it's more that like you don't run out, it just keeps coming. And it's more, as I say, the experience and the confidence of handling your breasts and going, oh, wow, look, I've got some before you give birth to the baby. And it was designed that way, that for the mothers who had gestational diabetes, the baby potentially could drop blood sugar levels, require a supplement. And so there was something there for the baby when the baby was born, dropped the blood sugar levels. In the event that a baby and mother are separated at birth, maybe the baby is a bit of TTN and goes up to the nursery, they go one way, the mother goes, oh, that's okay, I know what to do. I'll just express my milk and I'll give that to the baby. Even those small drops of colostrum are enough at the early stages. And what a leg up that mother has when she's shown how to express antenatally. It's more that, it's not really the stockpiling. I did have a mother who was, some women leak colostrum and they have a lot of it. This woman was able to collect quite a lot. She had maybe, I don't know, ample syringes, like 10 syringes of about 5 mils, and her baby wouldn't take the breast, so just couldn't get on. So she kept giving it this colostrum, which is fantastic. She wasn't expressing either. So wasn't sucking and she wasn't expressing. I think you missed the point there, So
there's another question up here, and then I've got some more online questions.
Awesome.
Sorry, me? Yeah. No, see your question. Oh, you don't want it? I want.
Okay. Oh, sorry.
They can hear the questions on.
So sorry, I've got a few more questions. Do you know whether, as an outpatient, women can get therapeutic ultrasound that's bulk billed, as private physios charge a lot for this?
Do you want me to repeat the question, or can they hear with that? They can hear with that. Cool. No, I don't believe it's bulk billed. But yeah, that's the thing. The women are accessing this when they see their physios, and some of them have 2 or 3 treatments. Yeah.
Apparently on one of the sources, and I'm not sure whether it's in the written stuff or on your slide, the phone number for the breastfeeding support unit is wrong. It's got too many digits. So could you just give us the number?
26370.
It says 719 apparently on that. Okay. The other question I have online is, what is your recommendation to stop breastfeeding for a child after 12 months or older? It's a very frequent question GPs get from mums weaning.
Say again,
what's your advice about kind of weaning and stopping breastfeeding in a baby when, after 12 months or so when?
The World Health Organization recommends babies are breastfed for 2 years and beyond. And that's why the MAF is not the WHO code. Like, that's why Australia's breaching the WHO code by advertising infant formula, follow-on formula. Don't get me started on that. We'll have another big, long day at it. So weaning is a very personal choice, and mothers should feel like they wean on their own terms. It's a breastfeeding relationship if they want to. There is nutritional benefit breastfeeding beyond that, but I think the practical answer that you're after is, should I stop abruptly? It depends how much milk's there, how often the child feeds. And if the mother wants to wean, that she does so on her own terms, and it's gradual. We don't recommend abrupt weaning because that's going to cause milk stasis and mastitis. Does that help?
Yeah. Medications required to cease breastfeeding?
Breastfeeding for that period of time. There is a prescription in the therapeutic guidelines using Dostonex before lactogenesis 2, so within the first 24 or 48 hours. And then the dose is different if you're going to take it to help wean.
Mm-hmm.
But it's always gradual weaning, always. Yeah.
But
yes. Breastfeed, reduce the breastfeeds and replace a feed. Express for comfort is different for everyone. It's very subjective. Some ladies can go a day without expressing, and some ladies can only skip 1 feed and then need to express. And you don't express all of it. You express just enough that you feel better, not empty. Because that's what triggers the negative feedback inhibitor of lactation, right? So if the breasts are full, those cells go, we're full. Don't release any more prolactin. So,
right. Thank you, Katy.
What was the?
In the community health.
Absolutely the child and family health do so well. I work very closely with them. We go to meetings together and they take over. See, the Royal Hospital for Women does home visits, like 4 days of home visits. They see them for 3 and miss 1. And then the child and family health take over. And there's a beautiful seam line from us seeing them to the child and family health seeing them. And they have IBCLCs in the Child and Family Health Centre, and they have lactation days as well. So the mothers can say, I'm going to come for my 1 to 4 week check, but I also have breastfeeding problems, and they allocate that time to see them just for lactation. So, and they do a great job. Yeah.
Okay. Thank you, Katie. Thanks so much for your input today.